Thank you to the organizers for inviting me to talk about the micro-elimination among men who have sex with men, MSM. The study I will present to you here was funded by an investigator-initiated study program from Merck, Sharp and Dome and by the Swiss HCVree cohort study. So to give you some background information, in 2016, the WHO released its first global strategy on viral hepatitis elimination. And the elimination goals are defined as a 90% reduction in new HCV infections and a 65% reduction in mortality by 2030. So what is micro-elimination? This refers to targeted elimination programs in defined populations as a strategy to assist these WHO goals. And these populations could be high-risk populations such as MSM, prisoners, hemophilic patients, or birth year cohorts such as baby boomer generations, or also geographic areas such as Egypt. With the availability, affordability and access of newest direct-acting antiviral agents, DAA, we are really successful in eradicate the virus in the patient. But what is clear now is that we have to go a step forward and to aim the goal of elimination. In this study, we concentrated on HIV-positive MSM from the Swiss HCVree cohort study. And this is because we see a very high increase of acute hepatitis C infections in this population. You can see here data from the Swiss HCVree cohort study, and this is a very representative cohort study of HIV-infected patients in Switzerland, where you can see during the last decade a dramatic increase in the number of incident HCV infections. An incident means that these infections were newly acquired. Whereas in the HIV-negative MSM population in Switzerland, the HCV prevalence is low and similar to the general population. So it makes sense to concentrate on the HIV-positive MSM with regard to the hepatitis C epidemic of MSM. It is clear that to reach the WHO elimination targets, the early identification and the treatment of potential HCV transmitters is key. So the aim of the Swiss HCVree trial was to test the feasibility of a HCV micro-elimination approach among HIV, HCV-positive MSM. In brief, the Swiss HCVree trial consists of 3 phases, A, B, and C. During the phase A, we tested every MSM included in the Swiss HCV cohort study by HCV RNA for replicating HCV infection. Following the screening phase, we then offered DAA treatment to all MSM identified with a replicating infection, with the goal to cure them, of course. And we accompanied this treatment phase with a behavioral intervention counseling program, which was developed by a team from Professor Dunja from Basel. And this behavioral intervention program was to reduce the risk of reinfection of hepatitis C after successful DAA treatment. Following this treatment and counseling phase, we then repeated the HCV RNA test in every MSM from the SHCS to assess the post-interventional prevalence. Of note, as a test, we used the PCR test, and this is a very sensitive diagnostic test which allows us to diagnose the hepatitis C infection very early, which makes sense because a lot of these infections are newly acquired and incident infections, and the serology might be negative at the time point when you assess this patient. Here are the data from the screening phase A. So we screened 3,722 MSM from the SHCS by PCR, and we identified 177 individuals with a replicating infection. Of these 177, 30 were incident, meaning newly acquired, and 147 infections were prevalent infections, meaning already known to the investigators prior to the study. So we had a prevalence of 4.8% of replicating HCV infection assessed in this screening phase A. Here are some baseline characteristics of the MSM with replicating infection. And what I want to mention is that the vast majority of the MSM with replicating infection had a low fibrosis score assessed by FibroScan, so F0 to F1. And this is of importance because at the time of the study, DAA treatment was only reimbursed by the health insurances for individuals with a fibrosis score 2 or higher, meaning that for 78% of the MSM, DAA treatment at that time point was only possible within the study. During the phase B, we then offered DAA treatment to patients with replicating infection. Gratzapavir/Elbasvir was provided free of charge in the context of this investigator-initiated trial by Merck, Sharp and Dohme. And for those which had contraindication to Gratzapavir/Elbasvir, we treated them with standard of care DAAs according to current guidelines. With these DAA regimens, we achieved very high curing rates. Overall, we had a cure rate of 99.5% of all treated patients. As mentioned earlier, the phase B was accompanied by a behavioral counseling intervention. This was for MSM reporting condomless sex with non-steady partners. The counseling intervention consisted of 4 sessions and was provided by trained counselors. Some of them are sitting in the room, such as Patricia or Manuela. And the counseling sessions were supported by the eHealth tool. And we saw a very high acceptance rate of this behavioral intervention program because 71% of eligible MSM completed all 4 sessions. During the rescreening phase C, we reassessed 3,720 MSM by HCV PCR, and now we identified 28 HCV PCR positive individuals. Of them, 16 were incident and 12 prevalent HCV infections not treated during phase A. So the post-intervention prevalence was 0.8%. It is worth to note that the majority of the incident infections were possibly acquired within international transmission networks. This was because we sequenced some of these strains and we could see that probably these incident infections were not acquired in Switzerland, but probably outside of Switzerland. And of course, this has implications for future elimination programs. On this slide, you can see the overall effect of our intervention. As you can see here, there was a strong decline in the incident infection rate from 31 assessed during phase A to 16 assessed during phase C, reflecting a 49% decrease, and an even stronger decrease in prevalent infections from 147 to 12, reflecting a 93% decrease. So to conclude, our systematic and population-based HCV PCR screening identified a high number of potential HCV transmitters among the HIV-positive MSM population from the Swiss HCVree cohort study. Our intervention led to a decline in the HCV prevalence from 4.8% to 0.8% and to a decline of incident and prevalent HCV infections of 49% and 93% respectively. Our study could serve as a proposed model to reach WHO elimination targets, but what is also clear with this high number of incident infections probably acquired abroad or within international transmission networks, that we have to keep our efforts very high. I think we did a nice job with regard to the decline of prevalent infections, but we still see this considerable number of incident infections. And what is clear from that is that joint global efforts are needed and that a systematic screening has to be repeated after such an intervention. With that, I would like to thank all the collaborators of the Swiss HCVree Trial, in particular Jan Fair, the sponsor of the trial, Huldrych Günthard, the president of the HCCS, Ben Hampel and Christina Grube, who did a huge job, the statistician team from Roger Cuyos, Wen and Katharina, Jörg Böhni and his team from the Institute of Medical Virology, all the principal investigators from the different sites in Switzerland, and of course, a special thanks to the team from Dunjanica, Patricia, Daniel and Manuela for the counseling program. And of course, also Merck for sponsoring this study. Thank you for your attention.